Okay, let's talk about anxiety. So, anxiety is defined as a state of apprehension, tension, or dread that stemmed from a real or a perceived threat to a person's well being. So, I want you to think of that fight or flight response. If you've ever gone through anxiety, how did that feel? Was your heart racing? Did you have that pounding, palpitations? Maybe you couldn't breathe or you're breathing too fast. You can't concentrate. You can't think clearly. You're just in panic mode. Panic mode. You need to get away. I think we all experience anxiety, time and again in our lives, and most of us can get through those episodes with regular coping skills, but sometimes that anxiety becomes chronic or it begins to affect a person's ability to perform basic daily activities, and medication becomes necessary to help with that. So if you ever have a patient that's worried about taking anything for anxiety, sometimes it could be just a one-time dose to help them through. They might need to go on a regular regimen for anxiety medications, depending on their situation. But just let them know that sometimes it's just necessary and it's not anything to be embarrassed about or ashamed of. So we're going to talk about some of these primary anxiolytic drugs that are commonly given for anxiety. Mainly benzodiazepines. That's kind of the first line drug of choice, as opposed to some of these others that might be used just because they don't have as serious adverse effects as some of the other drugs that might be tried, and they aren't. I won't say they're not habit forming because they are, but we don't tend to build up a tolerance to them like we would say to a barbiturate or an SSRI. Anyway, so benzos are typically the first line, and another miscellaneous drug that is used quite often is buspirone. Um, Benzos are also commonly given for sleep disorders, for muscle spasms, for alcohol withdrawal, and for seizures. And we'll talk about those. I'm not SSRIs. Those are pretty commonly given for anxiety as well. That would be like your Celexa or your Lexapro or Prozac, and those are medications that have to be taken continuously on a regular basis. They can take 2, 3, 4 weeks to build up in the system to even be therapeutic. It's not something that you would take for a one-time event, like you might take Xanax, or you might take a dose of Ativan that you're not taking all the time. I'm not going to really talk about SSRIs too much here, just because I will have covered it in the review for depression. Barbiturates, we'll note that they might be used for anxiety disorders, but that is really rare that they are used for that anymore because there are just too many serious adverse effects associated with those. And so we try to steer away from that. Okay, so when we talk about our benzodiazepines, this would be our like diazepam, lorazepam, clonazepam, alprazolam. Think of the Pams and the Lambs. There are other kinds as well, but these are the most common. Yeah, I think we're all familiar with Valium, Ativan, Klonopin, Xanax. Um, these drugs are very effective in treating anxiety, but they're used for other things as well. They can be either sedative or hypnotic, and it really depends on the dosage and which medication is given. So just keep in mind that when given in smaller doses, these benzos are great for decreasing episodes of anxiety, and they aren't nearly as likely to cause drowsiness as when we give larger doses. When we give IV, it's not as likely to last as long as an oral dose is. And so oral generally is a better choice unless you need it to act faster. If you've got a patient that's a highly anxious patient that needs sedation, then an IV route is going to be a better choice for that scenario. They can cause mild drowsiness, sedation, lightheadedness, disorientation, and dependence with long-term use. They aren't as likely to cause tolerance where the patient needs to start taking larger and larger and larger doses over time, but certainly there is a dependence factor that you need to consider. If you've got a patient that's taking any of these benzos on a scheduled basis, one point of patient education that you should be aware of is that they should never stop taking it very abruptly. A lot of patients take this just on a PRN basis, where they wouldn't have built up that dependence, but others have it scheduled. They are contraindicated in pregnancy or lactation, in coma, shock, or alcohol. It should never be taken with alcohol. In acute psychotic episodes, and patients that have narrow angle glaucoma should avoid it because it can cause problems with pressure in the eye. Um, when you're assessing patients that are taking these, you should be watching for respiratory depression or signs of oversedation. Okay, that's going to be a key assessment, a priority assessment for a nurse for any patient that's taking these under your care, especially if they're getting an IV dose. We want to monitor for signs of withdrawal, and those would be manifested by sleep disturbances, irritability, increased tension and anxiety, panic attacks, hand shaking and tremoring, sweating, difficulty concentrating, confusion or cognitive difficulty, memory problems, dry retching and nausea, weight loss, palpitations, headache, and muscular pain. And that would be things that you would see where it's a significant change in your patient, where they weren't doing that before and now suddenly they are. We really want to educate our patients not to drive until they know how these drugs are affecting them. And certainly when you've got older patients, just keep in mind that their renal function usually isn't what it used to be when they're younger. And so a lot of times this can build up to higher levels in the body and they might be not really steady on their feet. And so be assessing these patients for risks of falls. That should be a high priority assessment anytime you've got an older patient that's taking a benzo. Some other uses that we might use benzos for would be to relax a patient just before surgery. We can use it for anesthesia. We do use it to treat some cases of insomnia. We use it regularly in a CROP protocol for a patient going through alcohol withdrawal. Ativan, I don't even know how many milligrams of Ativan I will give in a 12-hour shift with an alcohol withdrawal patient. It becomes your best friend sometimes. Again, we use it to treat anxiety, but we also can use it for seizure disorders, and then to produce skeletal muscle relaxation. Specifically, when I think about that, I look at Valium. Valium is one of my favorite medications to use for a patient that has had a total knee surgery. Sometimes this muscle in their upper thigh just binds up and pinches a nerve, and it's just unending pain that you cannot give all. There's not enough morphine or Dilaudid in the world sometimes to relax that pain, but you give an IM injection of Valium right into that thigh muscle, boy, within 5-10 minutes, it's a world of difference, and it lasts quite a while, 6-8 hours. So we use it for many, many different things. I do want to point out that flumazenil is the antidote for benzotoxicity. Flumazenil, let me repeat, flumazenil is the antidote for benzo, not Narcan, okay? If that shows up in your test, do not choose Narcan. So the other medication that we'll talk about with anxiety is buspirone or Buspar. Buspar does have its advantages over benzos because it's not as likely to cause sedation. It has a lower abuse potential, and it also is not likely to increase CNS depression when it's mixed with alcohol. So this could be a really, really great choice if you got a patient population that you know is going to be drinking. The most common adverse reactions associated with it include dizziness, lightheadedness, insomnia, rapid heart rate, palpitation, and headache. You would want to tell your patients to avoid activities that require alertness and psychomotor coordination until the effects of the buspirone are known with them as well. It does have a slower onset of action than the benzos do, and so it's not as effective if quick relief from anxiety is needed. Okay, and then here's just some really basic patient education to go along with these anti-anxiety drugs. It's just important for your patient to know that these drugs are only going to relieve their anxiety symptoms, um, just temporarily, right? It's not going to cure or solve their underlying problems. And so working with them on coping mechanisms is always really great practice. Helping them identify supports in the community, a counselor, family members that they can confide in, um, or even practicing, relaxation techniques, meditation, yoga, mindfulness exercises, deep breathing can all be very, very beneficial with patients that have anxiety. Exercise is really, really a great stress reducer. When taking these medications, they should be avoiding the use of alcohol, but also cold medications and appetite suppressants that contain caffeine or other stimulants, because that can really exacerbate their nervousness and increase their insomnia problems. They should always tell their prescriber what other medications are being taken, because there are a lot of adverse effects with mixing different drugs with these medications. And again, avoid hazardous activities that require alertness. Do not smoke. And then lastly, take the drug later in the day or even at night as indicated to reduce daytime drowsiness. And this could be very medication specific in how it affects certain patients. But if they're taking medications that make them groggy, just encourage them to take it closer to bedtime. So here's a fun fact. Insomnia can cause anxiety, but anxiety can cause insomnia. So it can be this circle of which one, which is coming first. Is it the chicken before the egg? Is it the egg before the chicken? Um, but we do find that treating both simultaneously might give better results than addressing only one or the other. I don't know if any of you have any sleeping problems, but boy, I tell you, sometimes when I lay down to sleep, my mind just races like crazy and my heart starts to pound, and there's just no reason for it at all. Like, life is going great. I don't have any specific worries, but it's just like panic when I lay down. Um, and maybe you guys have experienced that as well. But it can really cause some problems with sleeping. And so in those cases, benzodiazepines could be a really great choice for that, as opposed to some other sleep aids that you might have tried. Um, One of them that comes to mind for me would be temazepam. That's pretty common for sleep. It's not one that you would want to be taking every night, because the body just kind of gets used to it and it stops being effective. But um, to take it once or twice a week can be very, very helpful. Some of the Z drugs, or it's kind of a term we use for non-benzodiazepines that we kind of lump in with them, would be like Lunesta or Ambien or Sonata. And we call them non-benzos because they mimic the actions of benzos in the brain, but they're not as habit forming. Only Ambien and Lunesta really are approved for long-term use, like for nightly use. Sonata would be for occasional use, because again, the body just kind of gets used to that and it just stops being effective. It's not habit forming, it just stops really working over time. So some things that you should know is some of these medications can cause hallucinations and or delusions, um, can cause amnesia, decreased motor coordination, and impaired judgment. And of course, dizziness, drowsiness, and lethargy. But I think that's the goal, right? I know for me, when I take that, I'm praying for or not for dizziness, but I'm praying for drowsiness and lethargy. So some patient education that you should be familiar with when talking about these sedative hypnotic drugs would be, of course, to keep this medication out of reach of children. Your patient should never be mixing these drugs with other CNS depressants. That could be opioids, that could be benzodiazepines, that could be even drinking alcohol. You would never want a patient to be taking like Xanax and Ambien at the same time. That could really lead to some respiratory depression and cause your patient to be overly sedated. It's always great to do some education about non-pharmacologic measures that might encourage sleep. Avoiding caffeine late at night, keeping a TV out of the room, getting some exercise during the day, not taking afternoon naps, going to bed at the same time and getting up at the same time, that kind of thing. Those can really, really help improve sleep patterns. It's important that your patient not drive or operate heavy machinery or participate in activities requiring mental alertness until they have tested to see how long these drugs stay in their system. I think the general rule is that they should be planning on getting 8 good hours of sleep if they're going to take these drugs. Some of them, like Ambien, do have a shorter half-life and aren't as likely to cause this hangover effect that many of these drugs do. That being said, you should educate that they may experience these hangover effects. And if you've ever taken something over the counter, like, oh, anything with Benadryl in it, that mental fog, that awful tiredness you have when you wake up in the morning, just let them know that might happen, especially in patients that have impaired renal or liver function, because these drugs just don't clear as quickly and they hang around a lot longer. And then it's always good to educate your patient that they might experience, what do we call it? Hypnotic amnesia, like Ambien amnesia. I don't know. You've probably all heard stories of people that have done funny things on Ambien that they don't remember the next day. So just let them know that they should be really, really cautious until they see how they react to these medications. Okay, so let's wrap this review up by talking about seizures here. So seizures are a result of abnormal electrical activity in all or part of the brain. It might happen just one time in somebody's life, or it might be chronic, but when we see 2 or more episodes occur, then that's when we call it epilepsy. Okay. Some causes might include fever, head injury, infection, metabolic or endocrine disorders, or exposure to chemicals or toxins. Or it might be none of the above. You might just be genetically predisposed to it. When we talk about endocrine disorders, this could be caused by, say, somebody in DKA, or somebody that's got a really high blood sugar could trigger a seizure episode. So it would do you a lot of good in your nursing practice to be familiar, so that you could take precautions against a potential seizure. Okay, so these are some of our types of seizures. Tonic-clonic are the ones that are known as grand mal seizures, and that's where it spreads through both hemispheres of the cerebral cortex, which is characterized by pretty major convulsions and rigidity, and the patient usually will lose consciousness. They lose control of their bowels. A lot of times they'll wet themselves. Our absent seizures, or the petit mal, are characterized by a loss of consciousness for a brief time, like 10 to 30 seconds, and sometimes it just involves like mild eye blinking or something like that, but they might not have any more motor activity at all. Atonic seizures are characterized by a sudden loss of muscle tone, and it's usually limited to the neck. You'll see a head drop occur, but once in a while it can involve the trunk and the arms as well. Let's see, we've got our myoclonic seizures. Those seizures consist of a sudden muscle contraction that lasts for just 1 second. Seizure activity might be limited to one limb, or it might involve the entire body, which would be a massive myoclonus. And then, let's see, febrile seizures. These are usually associated with children that are 6 months of age to 5 years. They typically manifest as a generalized tonic-clonic convulsion that doesn't last for very long. They're usually short duration. And it should be noted that children who experience these seizures are really not at high risk of developing epilepsy later in life. They're usually very, very specific to the fever. And then status epilepticus is considered a medical emergency, and it is characterized by seizure activity that goes on for 30 minutes, or could be repetitive seizure activity without the return of consciousness between events. That patient is at high risk for hypoxia, hypoglycemia, brain damage, and death. It is an emergent situation. As you read about a lot of anti-seizure medications, you might see different verbiage. You might see it be called anti-seizure. You might see anti-epileptic. You might see anti-convulsant medications. They all mean the same thing. Okay, they're just, those terms are used interchangeably. And the four types that we're going to discuss here would be your barbiturates, which your prototype is phenobarbital, benzodiazepines with Valium as your prototype, hydantoins, which would be phenytoin or Dilantin, and then hydantoin-like medications, which the prototype is carbamazepine. They all work in different ways by suppressing the brain's neuronal discharges. I do want to mention that all of these medications may cause suicidal thoughts, and so this is important to know. I don't know how much you've studied suicidal assessments yet, um, but it's something that you should be doing in your nursing practice anytime you have a new patient admit. Usually that's part of the charting system now. It's one of the core measures that we track because it has become so prevalent. And so you want to be looking to see if they've got these medications, be talking to them about any bouts of depression. How do they handle it? What kind of family support do they have? Sometimes these conversations can be kind of hard, but um, I just usually approach it very matter of factly, just like, oh, I see you're taking Dilantin. You know, that can lead to depression. Do you have any problem? You know, do you struggle with this in any way? And it just usually opens up just a normal, conversation where it could go to. So how do you handle that? You know, what kind of support do you have? Um, how helpful is your family? You know, is there anything I can help you with? You know, there's all kinds of places that we can send these patients to help them with community support or crisis consultations in the hospital setting if we need to. So just be aware of this suicidal aspect there and be do your due diligence and assess for high risk patients. So we'll talk about phenobarbital first here. It is a barbiturate. It affects the central nervous system. It's a depressant. It enhances the action of GABA in the brain, suppressing neuronal activity. It can be given oral, intravenously, or intramuscular. Phenobarbital does have a high risk of abuse associated with it, and so we just don't really use it widely anymore, but it can still be used for relief from insomnia, as a sedative, anesthesia, as an anti-anxiety medication, and we'll talk about it here as its use with seizures. It does have anticonvulsant effects to it. Tolerance can be built up to phenobarbital pretty quickly, pretty rapidly. And so physical dependence may occur even with a really small daily dosage. And it also has a lot of adverse effects associated with it that mostly affects the CNS, drowsiness, lethargy, headache, depression, but it also does have adverse cardiovascular effects. It can cause mild bradycardia and hypotension. It can affect the airway, resulting in hypoventilation or spasm of the larynx. It can lead to a reduced rate of breathing and severe respiratory depression. And then some other adverse effects that might be associated with this would be dizziness, vertigo, nausea, vomiting, diarrhea, epigastric pain, and allergic reactions. It is a pregnancy category D. It is absolutely contraindicated for pregnant women because of its propensity for addiction. It is a controlled substance, Schedule 4. And then I already talked about some of those adverse effects. And so if you do have a patient that is on phenobarbital, just be really, really wary when you're doing your assessments. Be watching really closely. Put them on a cardiac monitor. Make sure you've got, O2 waves being monitored, stuff like that. We'll just touch really lightly on diazepam again because we already discussed it in relation to anti-anxiety, but it is a benzo. It is a CNS depressant. It's not usually used for seizure activity by itself. It's usually used in conjunction with other anti-seizure medications just to gain short-term control. Valium wouldn't be used as a long-term anti-seizure medication. It might be given if seizure activity has just happened, or to stop seizure activity, you might give Valium at that time. It can be given orally, IV, IM. Do be aware the IV form always is given in a case of status epilepticus, because that's emergent, right? We wouldn't wait for it. Well, first of all, please don't ever give an oral dose to somebody actively having a seizure, because that would be a huge aspiration risk. But IM would take a longer time method, a method of action to become therapeutic. So IV is always the choice there. Be aware that Valium can be irritating to the vein, and so we always want to be flushing that well. Make sure that you've got a good IV site. It does have the potential for abuse, as all benzos do. And I know we already talked about some of the adverse effects with benzos, which would be drowsiness. We could have some hypotension, some tachycardia, some laryngeal spasm, cardiovascular collapse, and dependence. When we see cardiovascular collapse, that's very specific to IV form. It is contraindicated in patients with hypotension because it could cause hypotension, and so that could go down to dangerously low levels. Bradycardia, slow or shallow respirations, and intoxication, because these are all forms of central nervous system depression, right? And so we don't want to further exacerbate that. And again, one more final note here, that the antidote to all benzos is flumazenil. Okay, so phenytoin, or Dilantin is the brand name there, is usually the first line drug of choice for treating both tonic-clonic seizures and partial seizures. It works by desensitizing the sodium channels responsible for neuronal activity, which means that it helps the nerves, it helps stop the nerves from getting overexcited, basically. It is the oldest used drug and still the most commonly used because it's safer. It's not generally habit forming, and it does not generally cause CNS depression. It can cause some drowsiness, but not to the effect that phenobarbital would. It also has a relatively low risk for toxicity, which is another reason that it's used so often. It's given oral, and it's given orally or through the IV. Dilantin, I want to know, if you're giving it through the vein, it can be very, very irritating to the vein. We want to push this very, very, very slowly and flush it after. And you should be using a larger bore IV if possible, because you want it to be into a bigger, juicier vein, right? Dilantin should not be given faster than 50 milligrams per minute in adults, as it may trigger significant hypotension and cardiac dysrhythmias. If you're giving Dilantin through an IV, they should be on a cardiac monitor anyway. When we are giving Dilantin, or patients taking Dilantin, should be having their lab values taken regularly. Dilantin has a very, very narrow therapeutic range, which is only 10 to 20 micrograms per milliliter. If it's less than 10, then it's not generally helpful in stopping seizures, and if it's above 20, then it could lead to toxicity. And so they need to be following up regularly with their primary care physician to have those lab values monitored, and in the hospital you'll be wanting to track those as well. So some of our adverse effects include headache, unsteady gait, drowsiness, decreased heart rate, dizziness, decreased blood pressure, confusion, and swelling gums. The swelling gums, it's actually a proliferation where the gum tissue is growing. So you want to encourage regular dental exams there. But as you look at the rest of these, I hope that you're noticing, gosh, I sure hope I'm doing a fall risk assessment on this patient, right? Maybe keep them closer to the nursing station. Make sure they've got their call light with them. Make sure that they know how to ask for help, that they're not just trying to jump out of bed to get to the bathroom, things like that, because they would definitely be at an increased risk for falls if they had any of these adverse effects going on. Make a note that Dilantin can affect the metabolism of vitamin K, and if we're doing that, it's not it's stopping it. So remember, vitamin K, we would give, it's the antidote to Coumadin, right? If it's affecting the metabolism of vitamin K, then probably the blood is going to be have a propensity to bleed, to be a little bit thinner, to not coagulate as it should. And so just know that these patients are at higher risk of bleeding, and so you should be doing assessments looking for signs of bleeding. We never mix Dilantin with anything containing dextrose. It can precipitate in the vein. It's best to give it alone and then flush after with just a normal saline. But if you have to mix it into something, make sure that it doesn't contain dextrose. And then again, this is one of those medications that you don't want to stop taking suddenly because it might lead to status epilepticus. Carbamazepine or Tegatrel is a hydantin-like medication, anti-seizure medication, so it's very similar to Dilantin, but it doesn't have as many of the side effects associated with it that the hydantoins or barbiturates do. So it's becoming more and more popular as a treatment for tonic-clonic and partial seizures. I would say at this point it's probably the second choice treatment. It works very similarly by suppressing the flow of sodium ions in the brain. It can be given orally and through the IV. Again, this is another one where we want to monitor the blood levels. And just take note that carbamazepine should not be taken with grapefruit juice. Caution the patient not to stop taking this drug suddenly. That's a general rule with all anti-convulsant medications. And then if you look down here at the side effects, they're very similar to Dilantin, but there aren't as many there. But we could still have some drowsiness and dizziness and unsteady gait, some confusion. So again, do a fall risk with this patient if they're on it. No, blurred vision and rashes is specific to that medication. Okay, so here's some nursing considerations that you should be familiar with anytime you're taking care of a patient that has a seizure disorder. You're going to want to administer those medications very carefully per order, right? If given IV, watch for signs of extravasation. If you're giving any of these medications IV, they should be on a cardiac monitor, and you should be watching their oxygen levels as well. Monitor seizure activity. So if your patient has a seizure, note when it started, note when it ended, note what how they reacted to it. You know, were they conscious? What were the tremoring like? You know, the convulsions. Was there any motor activity going on? You need to be charting those kinds of things. And when we talk about providing patient safety, I don't know how many of you are already working as LPNs or CNAs, but if you've ever taken care of a high-risk patient at high risk for seizures, you're probably familiar with the precautions where we're patting the bed rails and we're keeping them close to the nursing station, right? We might keep a mouth guard close. We certainly, if they go into seizure-like activity, we want to make sure that they are safe, that they are not, that they haven't fallen, that they're not thrashing around with, you know, banging their head, that we've provided as safe an atmosphere as we can in the event that it does happen, that we're protecting the airway if we need to. Things like that. Monitor vital signs and lab values with these medications. Monitor patient's level of consciousness because these are CNS depressants. And then with all of these medications, they should be avoiding alcoholic beverages because that is a CNS depression as well. And again, don't stop taking that drug suddenly. Don't change brand names without physician supervision. Keep out of reach of children and take the medications continuously. So the goal of treating epilepsy is to reduce the seizures to an extent that it enables these people to have a normal or a near normal life. But we can't always eliminate that seizure activity entirely, just because of all the side effects that come along with these drugs. As you go back and review those, you see the dizziness, the nausea, the vomiting, the drowsiness that these patients live with on a daily basis, and it's can be more exacerbated with higher doses or when we start giving multiple drugs. It's important to know that not all anti-seizure medications are effective for all types of seizure activity. So we have to go through a lot of screening, a lot of testing, patient histories to figure out what kind of seizures the patient is experiencing so that we can pair it up with the proper medication. A lot of times patients have to try several anti-seizure different classifications before they find a treatment plan that is effective and that they can tolerate well. Again, all anti-seizure drugs can increase suicidal thoughts and behavior. And then it is important to know that women of childbearing years should be aware that many of these medications can alter the effectiveness of their oral contraceptives. There's like 8 of them that can make it not as effective. And of those, these 4, carbamazepine, phenytoin, phenobarbital, and topiramate, are associated with harm to the fetus. I know I told you already that phenobarbital is absolutely contraindicated in pregnancy. Phenytoin should be avoided if possible. It can cause things like cleft palate, some cardiac abnormalities. There's probably 4 or 5 things that could be not developed well in a growing fetus, but sometimes it's another one of those, what's the bigger risk? If this is the only medication that is working for that pregnant mom, then they may opt to just watch her very, very closely, maybe lower her dose through the pregnancy, things like that. So it's not a category X, but it is to be used with caution and discouraged if possible. Okay, so let's wrap this thing up with some patient education here. It's important that you teach your patient what adverse effects they might experience when taking anti-seizure medications. Some of them could get better over time. Some of them need to be reported to their physician. Some might be alleviated with a different dosage, or maybe it will be necessary to change classifications of medications altogether. So it's important that they know what to expect and what to report. Also, really drive home that they need to take these medications exactly as prescribed and that they should not stop taking that medication suddenly, because not only can it lead to increased seizure activity, but it might trigger an episode of status epilepticus, which we know can be life-threatening. Again, pregnancy needs to be reported immediately if it's suspected. Keep these drugs out of reach of children. Here's an important one. Your patient should never change brands without consulting their primary care physician. How many times do you go to pick up a prescription and the pharmacy has tried to substitute it with a different generic form or a different brand? It's really important that that does not happen, because when these medications are produced, they don't always carry the same rates of metabolism. And what that means in a different, if you took a different medication, your therapeutic levels might change. And we know that when we're keeping these therapeutic levels, it's a pretty narrow window. So just keep that in mind. Never should these be taken with alcohol. They should be taken on time to maintain therapeutic levels. So, if they need to set a timer on their watch, if they take it before bed, if it's every morning before breakfast, whatever it is, if it's 7 a.m., they need to try to take it at 7 a.m. every day. And keep in mind too that when you've got these patients in the hospital, that when you're administering them, that you need to be giving them on time as well to keep on that same schedule. Avoid taking carbamazepine with grapefruit juice. And then finally, follow primary care physician's recommendations for lab work to assess hematologic changes.